Hello, everybody. We're covering 10 high-yield Step 1 concepts. Be sure to like and subscribe. All right, the first question you might see on Step 1, we have a 9-year-old boy brought to the clinic by his father for a routine checkup. The father mentions that he's noticed some changes in his son's body odor recently. The child has no significant past medical history and is up to date on immunizations. He's at the 55th percentile for height and 50th percentile for weight. On physical examination, axillary hair development is observed, but there are no signs of testicular enlargement or penile growth. The father asks if his son's development is progressing normally. Which of the following is most appropriate response by the physician? Early puberty would require testicular enlargement, which he does not have, and so that's not the answer. Hormonal imbalance testing, that's unnecessary without abnormal growth or any sign of true puberty. C, the development is indeed within normal range. D, development of body odor is concerning and needs investigation. That is not true. That's expected. With Anarchy, it's not a red flag. And is that normal age-related maturation of the adrenal glands, which starts around ages 5 to 8. And it leads to an increased production of the adrenal androgens and the physical signs of puberty, like pubic hair, underarm hair, adult body odor, and oily skin in the hair. If this occurs before the age of 8 in girls and 9 in boys, then it might be a slight variant of normal development, but here he's a 9-year-old boy, so it's normal. And then height and weight means he's maturing faster than expected. Nope, the percentiles are normal, so there's no evidence of early maturation. 58th percentile, 55th percentile, totally normal. All right, this is just normal. The bottom line here is that axillary hair development with testicular enlargement indicates normal pre-pubertal changes, not early puberty. And a concept that I wanted to hit on is development. Around 8 to 11, the adrenal zone reticularis matures, and that increases this, DHEAS, which causes body odor, axillary hair, and mild acne. And this is independent of the HPG axis, so no testosterone surge occurs yet. And there's also no testicular enlargement, and so there's no true puberty. So you get the body hair because of that. You also get a little bit of body odor, but there's not testicular or penile growth. There's no central puberty yet. And typically we measure those T levels and they'll be greater than 4 milliliters if puberty is occurring. Okay, so the fact is that puberty does not begin with body odor or hair, and boys, the very first sign is testicular enlargement. All right, nicely done. Now on to our next question. All right, you guys are doing great. In our next question, we have a 15-year-old woman, or I guess a girl, presents to the clinic with increased pain in her left shoulder over the past month. The pain is constant and worsens at night. She denies recent trauma or injury. On examination, there's swelling and tenderness over the proximal humerus. An X-ray of the shoulder reveals a sunburst pattern. That should tell you what the answer is, or at least what the condition is, along with a mixed lytic sclerotic lesion of metaphysis in the humerus. Biopsy shows pleomorphic cells. That just means it has various, just different, distinct forms. Basically, pleomorphic means that you got cells and tissues, entire organisms that just vary in their size and their shape. Like a pleomorphic adenoma would be a tumor in the salivary gland with a diverse mixture of epithelial cells and myoepithelial cells, while pleomorphic bacteria can change their shape in response to the environment. In some cancers, like a pleomorphic, an undifferentiated pleomorphic sarcoma, the tumor cells will show significant variation in the form and the size. I always like to explain these words that we use almost every time they come up just so we can really hammer them home, because there's a lot of insider baseball in medicine. Vernacular to learn. So considering the most common site for metastasis of this disease, what should be assessed next? All right, so you have the answer here. The answer is indeed the lung, and this is osteosarcoma, which we should know because of that classic sunburst pattern. It spreads hematogenously, so through the blood and most often to the lungs. And so what do? You do chest imaging. That's super essential in diagnosis. And you guys have probably heard of the sunburst pattern, but that's whenever you have that brief appearance of the full sun behind the clouds, right? That's what the sunburst is referring to. It's like, sunburst. And now let's talk about the pathophysiology here. So it starts with malignant osteoblasts that produce the osteoid in the metaphysis. Osteoid is just like the bone stuff. It is the unmineralized stuff made by the osteoblasts. It's made up of primarily type 1 collagen and other bone matrix proteins. It's the precursor to mature the hard bone tissue. That's what the osteoid is. And the metaphysis is that wide trumpet-shaped part of the immature long bone. And that's the site for the longitudinal bone growth in childhood and adolescence. All right, so putting it all together, malignant osteoblasts, right, they're just churning out a whole bunch of that unmineralized stuff in the metaphysis. That leads to aggressive periosteal reaction, which is that sunburst pattern or Codman's triangle. And periosteal, by the way, is just a nice little adjective that describes something situated on or originating from the periosteum. And the periosteum is this fibrous sheath that covers the outer surface of most bones. It provides nourishment, sensation, and attachment points for the muscles and the ligaments, and it's super important for healing and growth, right? And so if you have that malignant osteoblast production making all that osteoid in the metaphysis, then you have that aggressive periosteal reaction, which is the sunburst look. And this will invade the local bone and the soft tissue. That's what causes the pain. We have some pain here. And that will then invade the local bone and the soft tissue, causing pain and swelling. And then it metastasizes early via the blood, especially to Where are the lungs, right? The pulmonary nodules. And this is commonly going to be seen in teenagers, in the metaphysis of the long bones, the sunburst pattern, the osteoid producing stuff. Lung metastasis is most problem. And so the answer is indeed B. Now, it's good to talk about some of the other answers here. So the kidney, well, osteosarcoma does not metastasize to the kidney. That'd be renal cell carcinoma metastasized to the bone. The pancreas is not associated at all. The spleen, rarely a site of metastasis. Honestly, I'll probably never see anything with metastasis related to the spleen. And thyroid can metastasize to the bone, but osteosarcoma does not metastasize to the thyroid. All right, so on step 1, if you see a teenager with bone pain at night that is swelling over the metaphysis and sunburst pattern on x-ray, it's osteosarcoma. And the hallmark is osteoid production by the pleomorphic cells. And what you have to worry about isn't just this like destruction in the pleomorphic cell stuff. It is actually the metastasis that could actually occur and spread to the lungs. And so the next step is always, every single time, what do? You image the lungs. Chest imaging, right? Look for metastasis, so look in the lungs. All right, the bottom line, sunburst pattern osteoid in young patients suggests osteosarcoma. Assess the lungs for metastasis is the next good thing that you should do, besides getting rid of this phantom arm right here. See that arm right there? Freaky, but I digress. Okay, for this question, I want to do something a little bit different. I want to talk about the science, and then we'll hit the practice question together. But today what I want to cover is, what does the science say about why smoking feels good? All right, and so let's just give the lay of the land here. All drugs of abuse, including nicotine, increase dopamine. And it increases the dopamine in the nucleus accumbens. And the nucleus accumbens, which I'll refer to as the NAC here, is a subcortical brain structure in the ventral striatum that is crucial for reward, motivation, and reinforcement learning. Cortical just means below the cortex. Ventral refers to like the underside part of anything, like an animal or plant. All right, so there's a structure inside of your brain which is crucial for reward. And it plays a big old role in behaviors like feeding, and it integrates signals related to motivation and a process of rewarding and aversive experiences. So you receive dopamine from the ventral tegmental area, which is referred to as the VTA. You receive that dopamine via the mesolimbic pathway. And this is what's implicated in addiction, depression, and other physiological disorders. All right, so the nucleus accumbens is the pleasure center of the brain. Pleasure, motivation, satisfaction, and it drives the behaviors that are essential for survival. It's also involved in learning and memory, right? So it associates the cues with reward that facilitate the reinforcement learning. And that's awesome because it helps us do things that drive desired outcomes. But this can go haywire in patients. That's the reason we're talking about it in a medical context. The nucleus accumbens regulates a variety of behaviors like eating, drinking, sexual activity, and social interaction even. But also aversive experiences are involved there because it teaches us how to avoid them. And the last thing I want to say about the nucleus accumbens is that it has extremely extensive connections. And that allows it to integrate signals from various brain regions to influence your behavior. All right, so a 45-year-old woman comes to the clinic and she's like, oh my gosh, I freaking love smoking. It gives me immediate pleasure and it's difficult for me to quit. She is asked like, hey, why is this so addictive? Which of the following neurotransmitter pathways is primarily responsible for the addictive pleasure that she's experiencing? All right, so is it serotonin release of the prefrontal cortex? Well, the answer is no. That modulates mood and anxiety, not the primary reward pathway. All right, so the answer is not A. What about B, norepinephrine and the locus coeruleus? Well, that's for arousal and alertness, not pleasure and reward. What about acetylcholine in the basal forebrain, right? D. Well, it's memory and attention, so no, not addiction reward. Endorphin release in the hypothalamus, pain modulation and euphoria for opioids, but not nicotine's primary mechanism there. All right, so the answer is C, dopamine release in the nucleus accumbens. All right, so if it feels really good when you smoke, it's not about willpower or personality. It's literally just your brain's wiring. Nicotine activates the receptors in the ventral tegmental area, then dump the dopamine into the nucleus accumbens. And your brain has that pleasure center, and so it's the same pathway that's hijacked by cocaine, alcohol, and opioids. And so the surge of dopamine is what creates the addictive pleasure, and why it feels so hard to quit. Dopamine in the nucleus accumbens. All right, and for those of you who just want a little bit more, the only other thing you could possibly be asked on step 1 about this is that nicotine binds to acetylcholine receptors in the VTA. And it's like, hey guys, depolarize, send this message of joy to the whole family. And you're increasing the dopamine release. So dopamine then enters the nucleus accumbens, and you get this feelings of reward and pleasure, and that reinforces the positive reinforcement, and that causes addiction. All right, the bottom line here is dopamine release in the nucleus accumbens drives the addictive pleasure of smoking. All right, this question, we have a 72-year-old woman with back pain, anemia, hypercalcemia. Okay, we already know what this is. That's the Crab criteria for multiple myeloma, right? You know Crab, don't you? He's a good guy. Just kidding. I used to play chess. I was on the chess team at Harvard, and there were a lot of people without homes who played chess in the square. And they would always, one of them would always speak with this exaggerated voice. He'd be like, you know Crab, don't you? So anytime I think you're here or want to say something weird, I always say in that voice. Anyways, Crab, okay? C stands for calcium elevation. R stands for renal involvement. A stands for anemia. B stands for bone pain. All right, so calcium, renal, anemia, bone pain. That's the Crab criteria, right? So you have the apple green, bifurcations, and Congo red. All of that tells us that we have some amyloid deposition. Why do we have amyloid deposition? It's secondary to multiple myeloma. Okay, so let's zone in on this amyloid light chain, this AL, amyloidosis. particularly when it's secondary to multiple myeloma. Let's just explain how this works, right? Because we have to know it for step one. There's no way around it. You just got to know this. And that's why I moved myself over to this side so you guys can kind of see all of the stuff I'm about to do. Amyloid light chain amyloidosis is a disorder that's caused by the misfolding and the deposition of immunoglobulin light chains. Usually we call these guys lambda or kappa, and they're produced in excess by the abnormal plasma cells. And when multiple myeloma produces excessive monoclonal light chains, these can misfold and aggregate into insoluble amyloid fibrils. And these deposits in organs like your kidneys or your heart or your liver or the peripheral nerves. Now, it's not extremely important to know all those guys, but essentially the mechanism here is there's the plasma cell to the organ damage. So the clonal plasma cell disorder, like multiple myeloma, causes the overproduction of these free light chains. And these light chains misfold and they form beta-pleated sheet. And these fibrils deposit extracellularly into the tissues and they disrupt that normal organ architecture. And you get the Congo red staining, which deposits the apple green boots with the bifurengence under the polarized light, right? And the organs then become dysfunctional, like they have the renal failure, the restrictive cardiomyopathy, all that good stuff. And so the most common that you'll probably see tested on this is the kidney. It's the renal involvement because you get deposition where in the glomeruli and the mesangium. And this is nephrotic syndrome or progressive renal failure is what you'll see with this amyloidosis and this light chain because the plasma cells are going haywire. So on biopsy, you have amorphous eosinophilic deposits and the Congo red stain that's positive, apple green boots with the fur, bifurengence, can also involve blood vessels and tubulointerstitial compartments. And so how do you recognize this from multiple myeloma? Well, the classic presentation is going to be somebody who is like an elderly patient. That's why I drew out 72 years old female, a young, sprightly young lassie who is feeling fatigue and weight loss and the crab features, okay? If you can recognize the crab features, you'll be A-okay. In fact, one of my friends recently took step one and she said, crab features. You got to know them. It showed up twice, right? So calcium, renal problems, anemia, and bone pain, right? Crab. Just get that in your head. Elevated calcium, renal dysfunction, anemia, and bone pain. Say it like as many times as you want. Name your dog elevated calcium, whatever it takes to get that in your head. Monoclonal spike of the serum protein electrophoresis, right? Look out for that. And also the elevated free light chains in the urine or the serum in the biopsy, proven amyloid with the Congo red stains. For treatment, you address the plasma cell. So dyscrasia is just the abnormal disordered state of the body. Kind of a fun, fancy word if you want to impress people and also confuse them at the same time. But anyways, the answer is amyloidosis, my friends. I don't get too much crazy into the weeds, but it's a combination of this dyscrasia, Congo red, renal, amyloidosis, AL type secondary to multiple myeloma. Hopefully I explained that pretty well. So you have a renal amyloidosis and also Bence-Jones protein on urine analysis. All right, so that's pretty much everything that I wanted to explain on this question. But in multiple myeloma, you have abnormal plasma cells that proliferate in the bone marrow, and these plasma cells produce monoclonal immunoglobulins. Particularly, they're going to produce IgG and IgA, along with an excess of free light chains, which I described earlier as your kappa or your lambda, and the light chains circulate freely and overwhelm the normal protein folding mechanisms. And so you have misfolding of the light chains, the free light chains. They misfold the beta-pleated sheet structures, which resist normal degradation, and then they aggregate in the amyloid fibrils, and they cause insoluble protein deposition in the kidneys, glomeruli, and mesangium, in the heart, restrictive cardiomyopathy, and in the liver, and the nerves in the GI tract. So Congo red staining is how you see them. They demonstrate the apple green bifurengence, and they're pathognomonic for amyloid. If you're finding what I'm doing here helpful, then please consider liking and subscribing. Monoclonal spike in that apple green stuff tells you amyloidosis is a likely diagnosis. And our next question, a 70-year-old woman presents to the clinic with a 2-month history of progressive difficulty walking due to numbness and tingling in her feet. She has a history of hypertension and diabetes, for which she takes lisinopril and metformin respectively. She was recently treated for latent tuberculosis with isoniazid, but she did not take the recommended vitamins. Oof. On examination, she has decreased proprioception and vibratory senses in her extremities, which of the following deficiencies is most likely the cause of her symptoms. All right, so this should just be on the tip of your tongue. In fact, you can just answer this one with buzzwords. The answer is C. Vitamin B6 goes with isoniazid. If you know that, then cool, good job. If you want to learn the mechanism, we'll do that briefly. So isoniazid interferes with pyridoxine metabolism that causes a B6 deficiency. And pyridoxine is that colorless basic solid that you often find in the cereals, liver oils, yeast. And it's really important in the metabolism of unsaturated fatty acids like vitamin B6. All right, so pyridoxine metabolism requires that B6. And so you have that B6 deficiency, which leads to the peripheral neuropathy and also the loss of vibration and proprioception. Okay, some other answers and why they're wrong. Thiamine, and nicely they give us our B1. That causes beriberi or Wernicke's-Korsakoff. And beriberi is the inflammation of the nerves in the heart failure caused by deficiency of vitamin B. Wernicke is not isolated to that peripheral neuropathy from the INH. Biotin is our B7. And that's a deficiency from raw egg white ingestion. Causes dermatitis and alopecia, not neuropathy though. This would not cause any neuropathy. And vitamin C is scurvy. That's poor wound healing. And iron deficiency is going to be microcytic anemia, fatigue, and neuropathy. All right, so this question is really just a textbook case of pyridoxine deficiency caused by isoniazid therapy without vitamin B supplementation. They literally tell you she doesn't take it. And so our bottom line here is that the numbness and tingling and the loss of proprioception and vibration tells us we have low active B6, pyridoxal phosphate, which is a cofactor that's required for transamination, and neurotransmitter synthesis. And so you get sensory neuropathy. All right, so feel free to pause. Let's look at these CHOP answers. Remember, it's B6. In our next practice question, a 30-year-old woman is seen in the outpatient clinic for a follow-up visit. She recently recovered from a respiratory infection caused by rhinovirus. During the visit, she expressed concern about the possibility of reinfection as she frequently travels for work. To ease her concerns, you explain that her immune system has developed a defense against this. Which of the following explains the mechanism by which her immune system will protect her against reinfection of the same virus? Okay, so upon re-exposure of the same rhinovirus strain, the immune system neutralizes the virus via antibodies, which bind the viral capsid proteins and they prevent the interaction with the ICAM1 receptor on the epithelial cells. And that halts the infection before the virus can even enter the cell, and that provides protection from reinfection. So rhinovirus immunity is strain-specific, and there are many serotypes that exist, but you get these neutralizing antibodies that block the receptor binding, and IgA and IgG prevent the reinfection, not intracellular killing. And there's no latency, no integration. Protection relies on antibody memory. La da 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 da. Remember cats, memory, right? So really briefly, it's important to know the pathophysiology of this. I like a button that goes pathophys, pathophys. Rhinovirus infects the respiratory mucosa and that activates the immune response, right? And then we get an activation of our B cells. Ciao. They produce the strain-specific neutralizing antibodies, and then upon re-exposure of the same strain, antibodies bind the viral capsid. So this blocks the viral attachment to the ICAM1 receptor on the epithelial cells, and so the result is there's no reinfection. All right, now there are a lot of juicy answers for us to choose. Activation of natural killer cells, that's innate immunity that's used for early viral response, not memory-based stuff. B is our right answer. Suppression of the viral protein synthesis, that would require the virus to enter the cell first, and antibodies prevent re-entry. Direct lysis of the virus-infected cells. That's the CD8 positive T cells that kill infected cells after the infection has occurred, not preventative. And then the inhibition of viral assembly and maturation also occurs after the infection, not relative to the prevention of the reinfection. So after you beat the common cold caused by rhinovirus, your immune system doesn't forget. It never forgets. Instead, it creates the neutralizing antibodies that latch on to the same viral strain, and they stop it from ever getting in again. The antibodies block the virus from binding to ICAM1. Think of ICAM1 as like the door to the house they're trying to get into, and they're like, nope, I'm locking this, so you'll never be able to get in. So our bottom line is immune protection is primarily due to the neutralizing antibodies that block the receptor binding process. All right, in this question, we have a 62-year-old woman presented to the clinic with persistent swelling and pain in her left knee, which has been increasing over the past 3 months. She has a history of rheumatoid arthritis managed with methotrexate. Physical exam shows a warm, swollen left knee with a decreased range of motion. Arthrocentesis is performed and synovial fluid analysis shows an increased white blood cell count, predominantly composed of lymphocytes. The fluid is cultured, yielding no bacterial growth. Radiographs of the knee show joint space narrowing and erosions. To investigate the immune process further, flow cytometry of the synovial fluid is carried out, focusing on T lymphocyte populations. These T lymphocytes are found to be active due to antigen presentation. Where did the antigen presentation most likely occur? Alrighty, so rheumatoid arthritis, RA, presents extracellular antigens to the CD4 positive T cells via the MHC2 complex. And extracellular proteins are processed for the endosomes and lysosomes, where they're degraded and loaded onto the MHC2 molecules before they're displayed on the cell surface, right? So these proteins have to interact with these endosomes, they're processed inside of them, and then they're degraded and they're loaded onto these MHC2s. So protein to endosome to MHC2. This is not the ER is MHC1 pathway, or the mitochondria or the Golgi of the nucleus, right? So the Golgi is the packaging. It's not where the antigen loading occurs, so it's not the Golgi. Rough ER is where the MHC1 loading happens, not the exogenous stuff. The mitochondria is energy production, so nothing there. And then the nucleus is the gene transcription, not the antigen binding site. So the antigens get loaded for presenting, and for CD4 positive T cells, it's not in the ER, it's the endosome. And that is where extracellular proteins are chopped up and placed onto the MHC2 molecules before they head to the surface. All right, in our next question, a 52-year-old woman presents to the clinic with a 3-week history of fatigue, irritability, and tingling of the hands. She reports recent muscle cramps and that she's been more forgetful than usual. Physical exam shows dry, coarse, and brittle nails and positive Trusso sign where her blood pressure is checked. Vital signs are normal. Lab analysis shows serum calcium of 7 and phosphorus level of 5.5, which the following is the most likely diagnosis. All right. So we got some key facts that we got to talk about for this condition. I see that cramping, I see that tingling, and then brittle nails, and I'm thinking hypoparathyroidism. So the key facts are hypocalcemia and hyperphosphatemia and Trusso sign. all indicate hypoparathyroidism. And so there we have our low PTH, which leads to low calcium reabsorption and decreased phosphate excretion. So basically we have our 52-year-old woman. She's got neuromuscular irritability. She has the tingling, the cramps, and the positive Trusso sign. There's cognitive changes, so irritability and forgetfulness. There's the dry, coarse skin and the brittle nails. That's the hypocalcemia coming in. All right, so this is the hypocalcemia. And indeed, our calcium levels are just at 7 and the phosphorus at 5.5, which is high, and the calcium at 7 is low. And it's all due to that low PTH. And low PTH causes low calcium reabsorption of the kidney, low calcium mobilization from the bone, low calcitriol activation that causes low intestinal absorption, and increased phosphate retention because PTH normally promotes phosphate excretion. And then you probably are wondering about this Trusso sign thing. That's the latent tetany due to hypocalcemia. All right, so that's another one of the calcemia problems. So that's Trusso's sign. And here are the other answers. Primary hyperaldosteronism would show hypertension and hypokalemia. Graves' disease would have a heat intolerance. That's hyper. And secondary hyper is be related to chronic kidney disease, and the phosphate would be high, but the calcium typically low to normal due to compensation. And then the vitamin D deficiency would have low calcium and low phosphate. We don't see that here though. All right, in our next question, we have a 22-year-old college student presents to the campus health clinic with a 3-day history of painful urination and foul-smelling thick yellow discharge from the urethra. He reports multiple sexual partners admits to inconsistent condom use. He denies fever, but mentions that the scrotal pain worsens when walking and improves when he lies down and elevates the area. On examination, there's tenderness on palpation of the right epididymis and notable purulent urethral discharge. NAAT is performed on the discharge. Which organism is most likely responsible for this condition? Alrighty, so we got a young boy who shows up with painful urination and a thick yellow discharge. Then you should think of gonorrhea, because if you see the yellow discharge, you are gone. But especially if he's sexually active with multiple partners and not using protection. So this discharge is purulent, which means that it's got pus, right? Containing discharging pus. That's what purulent means. And the scrotal pain that gets better with elevation, that immediately should point you to epididymitis. And I know that I've covered this in another video. So if you're watching the channel at this point, you should be in pretty good shape. But this is classic presentation for Neisseria gonorrhea, which is confirmed with the nucleic acid amplification test. And that's the reason why the right answer here is Neisseria gonorrhea. Okay, so our answer is D. Now we got to break down the other one. So chlamydia trachomatis, that is the more common overall, but it causes a clear watery discharge, not purulent. All right, so I'm going to draw chlamydia in blue, watery discharge, not purulent. E. coli is common in older men post-surgical patients, but it's not typical in the young sexually active males. Klebsiella causes granuloma inguinale and a painless ulcer, not urethritis. Urethritis is the inflammation of the urethra that we see in this patient. And Treponema pallidum is the syphilis, which causes a painless chancre, not discharge or epididymitis. And so really it's that thick yellow discharge which is cueing us into this, and also the NAAT positive for gonorrhea, and the scrotal pain that improves its elevation immediately tells us this is epididymitis. And the gram stain is gram-negative diplococci inside of the neutrophils, and the treatment is ceftriaxone and doxycycline for possible chlamydia co-infection. So here we do need the ceftriaxone and doxy as well for possible co-infection. And the real kind of mechanism here is just unprotected sex. So you get Neisseria gonorrhea that enters the urethra. And then the bacteria adhere to the mucosa. They do that how? Pili. That's a question that you might see. And then they invade and cause inflammation, urethritis, and they can ascend and infect the epididymis, causing epididymitis, and that presents with dysuria, purulent discharge, and scrotal pain, but you lift it up, you elevate it, and the epididymitis doesn't hurt anymore. So all that points us to Neisseria gonorrhea, gram-negative diplococci, Diplococcus, that is the cause of epididymitis. So it's that urethritis in a young male, so just Neisseria gonorrhea. All right, for this question, we were asked to identify the type of study design. Case control compares past exposures with those with and without a condition retrospectively. Cohort follows a group over time. Prospective, cross-sectional measures the exposure and outcome at the same time, like a Snapchat. Case series is similar individuals, and randomized control is the gold standard. With that being said, we have a very easy practice question to end our nice little video on. We have a group of 2,500 adults in metropolitan city, randomly selected and surveyed about their dietary habits and their current blood pressure levels. As you can see over there, we got our nice stunning man with his blood pressure cuff. The data is collected on the frequency of fruit and vegetable consumption along with the simultaneous measurements of systolic and diastolic blood pressures. Which of the following types of studies is this an example of? The answer is cross-sectional, right? Because you're just measuring both the exposure, which is the diet, and the outcome, which is the blood pressure, at the same time. And there's no follow-up. You're just, boom, let's examine everything and let's freaking do a cross-sectional study. We did it, folks. And this is important because imagine you're like me. Now I'm the person getting my blood pressure checked. You guys are going to be the one who treats me someday when I'm old, gray, and wise. And you'll have to know. Cross-sectional study design assesses dietary habits and blood pressure at a single point in time. Now, all I'd like to know from you guys is, was this helpful? If it was, go ahead and like and subscribe. I would really appreciate that. It helps with the channel. And hopefully you guys are having a great dedicated period out there. Give yourself a pat on the back. You're doing so well. Thank you for choosing the path to become a physician. And we'll see you guys in the next video.